welcome to this session where I think we are going to discuss a few briefs about what to do, what not to do. It's just around the corner, maybe just around 2 months' time. All of you will be appearing for the NEET PG, and many of you will be appearing for the INICET, possibly before that. So it's just around the corner where all of you are being preparing for maybe a year, or some of you more than that. And you have already faced through a lot of exams in the past, and you have been attending various of your mock tests, and you're preparing well. So this purpose of this webinar is just to give you a heads up in some way and maybe help you understand maybe what better can be done in this last few days of preparation of NEET PG. So as of all of you know the pattern I think changed last year. Little changes came into it. So otherwise the standard pattern, you have 200 MCQs, 3 hours, 30 minutes. It's a computer based preclinical, paraclinical and clinical subjects. The marking scheme is +4 and -1. That's +4 one for correct and -1 for the incorrect. What changed, I think, last year was that this 200 marks have been divided into 5 sections. 5 sections of 40 questions each, and each section is 42 minutes. So 40 questions have to be read, understood, attempted in 42 minutes. Because the most important thing that came up was that there is no gap between these two blocks, these 5 blocks which have been kept. And once that block is over, you can't return back to that. That is something which has maybe got a little of more competitiveness here, that each block has to be finished, only then you can go to the next block and you can't come back to the block again. So that is something that you have to remember. So please remember that 40 questions you have to finish in that 42 minutes. And that means if you see roughly there is just around a minute per question, and the questions can be of various types. It could be a single line, it could be a a STEM clinical case that could be there, and then the options also might not be just a single option. It could be a approach based thing. So very important for us to know. Earlier you had those 200 MCQs for the entire 3 hours there, where you could maybe come back, you could mark and go and come back. Now earlier we used to always say that in the first round answer which 100% right, and then you go to the next ones, and the last one you can only choose later. But that is not going to happen now. Now each of these sections you will have to finish to go to the next section, and each session there is no gap between the two the 5 sections that you have. That's something which has added a little more complexity to the exam. That's the same pattern that was there. I think the NEET SS which happened yesterday, similar pattern, only the blocks were there, and the first block had a lot of long questions, and many of the students who attempted it did say that to finish the first block was difficult. The later blocks were okay, but the first block had a lot of long questions. The stem was very long, so to read it and understand it was a little difficult. So that one problem is going to be there, which you should be prepared for. And the way you go forward, that you have to always remember. The syllabus breakdown, you know that the preclinical has 10 to 15%. Most of it is applied to the clinical subjects. Same with the paraclinical, which has around 20 to 25%, out of which pharmac and community medicine has the highest weightage. The clinical subjects have the highest weightage, that is 60 to 70% of the entire paper. So anywhere around 130 questions would come from clinical subject, and medicine would have around around 30 to 40 questions plus. Most of the time you would have it, and that would be coming from medicine, surgery, obs-gynae and pediatrics, radiology, dermatology and psychiatry also. And of late what you're finding is a lot of paraclinical or preclinical questions are linked to the clinical subject. So though it's a clinical case scenario given, the answer is lying in the pathophysiology, or answer is lying in the pharmacology part of it. So a lot of clinically relevant questions are there that's coming. So this is the gross weightage. As of the latest breakdown which has come, this is not a hard fast breakup. The number of questions from each subject: in the preclinical, anatomy has around 11 questions, physiology 11, anatomy has 17, physiology 11 and biochemistry 16. Again, these are predominantly applied questions. In the part B, which was the earlier portion, that is the preclinical, paraclinical portion. 25 for pathology, 26 for pharmacology, micro 20, forensic 20, and social and preventive medicine 25. Pharmacology has got the highest in this, so 26 marks have come from them. And from the clinical subject, if you look at medicine and allied, 45 questions, surgery and allied 45, Ops Gynae is 30, pediatrics 10, ENT 10, and Optal 10. Again, this is the rough division, so almost similar numbers are always given. But again, remember the mix will be different. So those 5 sections will be a mix of all. It will not be like first section will be only preclinical, nothing like that. All questions will be mixed. So you will have 40 questions of any of these combinations in each of those 5 sections that are there. So, definitely medicine has a high weightage. You have super high yield topics also over the years, over the last 4-5 years. The super high yield topics which have been there in medicine, predominantly infectious diseases, HIV, TB, malaria, dengue, and the arthropod-borne viruses. Cardiology, you get a lot of image-based ECG questions. Heart failure, infective endocarditis has been asked. Neurology, predominantly stroke, epilepsy, and acid-based disorders. You definitely have 1 or 2 questions on this. Surgery also, you have a lot of surgical anatomy question, abdominal emergencies. In gynecology, contraception and labor. And in pediatrics, very important is your nutrition, neonatology, that's the milestones and the vaccination schedules. So these are the high yield topics that are definitely, you do get a lot of questions from. A little brief on each of these in the portions of medicine I'll just cover. Under cardiology, you do have congenital heart diseases. You do get some questions on common types of congenital heart diseases. Please remember, VSD is by far the most common congenital disease, total put together. But if they ask you in adults, bicuspid aortic valve is the most common congenital heart anomaly. They can ask you straightforward questions. Angina treatment, beta blockers could be there. STEMI, what do you do for STEMI? Again, you definitely have a question on MI. So within 90 minutes, you can do a PCI. And if it is later than that, you can do the thrombolysis also. Hypertension in young patient, and then you have a renal angiography showing string of beads, fibromuscular dysplasia. So hypertension, secondary hypertension's management, atrial fibrillation and other arrhythmias. AF, you generally have 1 question on the, the rate control, rhythm control, whatever portions are there, that will be covered in that. So it does have a weightage there. From the pulmonology, the obstructive airway disease is a very, very important topic. The COPD, the bronchial asthma, how do you diagnose it, reversible, irreversible, and what is FEV1 by FEC, the staging of COPD, all you get questions on that. Sarcoidosis, a very, very common question. You will have an image or pathology slide or X-ray or maybe the clinical scenario. Sarcoidosis, a very common questions asked. Pneumonia, you do expect questions on the clinical features, the curve 65, the most common organism. Hematology, almost all sorts of anemias are important. The important one being microcytic or macrocytic. What is the peripheral smear finding? You do get 1 or 2 smears and they ask you to identify the abnormalities and what are the types of things that could be there. Also, please read about the microangiopathic hemolytic anemia, that is the TTP and HUS. You do get questions from that. And the genetics of the malignancies like CML, you have the BCR-ABL. You can have the genetics for the Burkitt's lymphomas. So myeloma is also an important topic that's asked. And you do get 1 or 2 questions on transfusion biology also. Infectious disease again has a lot of weightage, both in medicine, microbiology, as well as in pharmac, also community medicine. You get a lot of questions from this section. Tuberculosis, very, very important. Again, remember the tuberculosis regimen has changed of late. That is in the last month, but yes, in India, the regimen still holds the good. That is the 2 HRZE and 4 HRE only. The rifampicin based CDC has changed, but Indian guidelines have not changed. So you can follow the same. Next is HIV. A lot of questions are asked on HIV, be it clinical scenario based or the image based. And very important, they give you a CD4 and then they give you some symptoms. What is the disease? What is the prophylaxis? So that's an important thing that you remember. CD4 below 50, what comes? MAC comes, primary CNS lymphoma comes. So you know that cryptosporidiosis will come there. Typhoid, again, a very common questions asked. And dengue, you do get questions like the what are the warning signs, and the other arboviral diseases are also important. Sepsis and pyrexia of unknown origin is also an important topic that is. So these are the common topics which I have given you, not that these are all the rest. You do have other portions like the rheumatology, immunology, the portions of toxicology you do get questions on. And then you could have questions on the environmental medicine. That's also coming up. And very important topics that has come up now is the geriatric, palliative care, the pain management. You do get questions on that. So the next few minutes, let's just overview some patterns of questions. All of you know about it. I'm just re-emphasizing. So how do we quickly answer these questions? Because as I told you, you have around 30 seconds possibly to read the question and read the options and then arrive at a diagnosis. Like supposedly a question is asked, a 55-year-old smoker, crushing retrosternal pain radiating to the left arm. So, you know, it's MI that's there. And the ECG, they can give you an image or they can give you the findings. Like here they have written, ECG showing ST elevation in 2-3 AVF. Again, remember the answer could be just MI. It's an inferior wall MI. But the question asked here is, which is the most likely artery involved? So please remember, inferior wall MI could be due to the right coronary artery or the left circumflex artery. So based on the findings, what option is given there, that is how you decide on it. So it is an inferior wall MI. A right coronary artery is the most common, but it can be left circumflex only based on the ST elevation in 2 more than 3. If in lead 2 it's more than 3, we consider it as RCA. If it is 3 more than 2, it is LCX. Again, remember, if you find changes in the 2-3 AVF, it is inferior wall MI. If it is V2 to V4, then it is an anterior wall MI. The vessel that is supplying is left anterior descending. So here, this sort of questions will amalgamate not only cardiology, they will also amalgamate anatomy there. So that is how the applied questions are coming. And you do find a lot of questions of this pattern, which is appearing in the questions. The next is HIV positive patient, CD4 less than 100, has headache, fever, and ring enhancing lesions in the brain. So again, remember, ring enhancing lesions could be many things. It could be tuberculoma, it could be toxoplasma, it could be cryptococcus, it could be primary CNS lymphoma, it could be PMLE. But here they have given you a clue, the CD4 is less than 100. So less than 100, the most common or most vulnerable, what you get is the toxoplasma. You know, tuberculosis comes less than 200 itself. So toxoplasma is most likely the answer. So you should know the treatment. So the question may not be what is the diagnosis. They may ask you, how do you treat it? So you should know that it is treated with pyrimethamine sulfadoxine, sulfadiazine, not sulfadoxine, along with leucovorin. That's the treatment point that you have to remember. So pharmacology is linked to that. The next example is the triad of Wegener's granulomatosis. Again, remember the Wegener's granulomatosis term is no longer used. You may be asked as GPA. That is granulomatosis with polyangiitis, that's there. So the triad, so it's upper respiratory, lower respiratory, and kidney. That's the combination. So they can give you various combinations, 2 of which might be right. So sinusitis, pulmonary nodule, and necrotizing glomerulonephritis. And C ANCA is positive. That is C ANCA is against anti-PR3. That is also an important MCQ that is there. So such questions which are linking to a clinical scenario, but final answer is either biochemistry or anatomy or a pathology question that is there. So such questions are coming. So drugs are asked, what is the culture media they ask, but it's a clinical question that is asked. Then in your entire 200, around 20 questions could be rapid recall, which you should be able to identify and answer straight. This sort of questions has to be attempted straight. Like I can see here, most common arrhythmia in hyperthyroidism. Now again, remember they have asked arrhythmia. So if they ask arrhythmia, it is atrial fibrillation. But please remember the most common cardiac abnormality or the rhythm abnormality that you see is sinus tachycardia. So it depends upon you what option is there in that. If atrial fibrillation, that's the right answer. There is drug causing red man syndrome. There is no question to be thought or not. It is vancomycin. So you just have to attempt it. Classical murmur of aortic stenosis is a ejection systolic murmur, crescendo decrescendo going to the carotids from the aortic area. The diagnostics test of pheochromocytoma. This is just recall. This is just recall. That is the 24-hour urinary metanephrosis. So such questions you have to identify and answer it straight. You should not take more than 15 seconds for these questions. Of late, what we are seeing is a lot of image-based questions. I think in the last 2 or 3 NEET PGs, at least more than 25 to 30. That's almost 15 to 20% of all your questions have been image based. So over the next few minutes, let's just overview few of the patterns that can come. So here we have a smear that has been given to you. So a 28-year-old female, progressive pallor, shortness of breath, and the HB is 8.2, MCV is 72, MCH is 22. So you know that there is this patient is having it. Here in the question itself, they mentioned peripheral blood smear showing microcytic hypochromic red blood cells, target cells, and pencil cells. What is the diagnosis? Now, sometimes they may not tell you the peripheral smear finding. They may just give you the image. Based on the image itself, you'll have to identify. So here the image is showing microcytic. You can see the central pallor there, and the size is very small. You can see these pencil cells, and some target cells are also there. You can see these are the target cells. So what's the diagnosis? It is iron deficiency. But remember, microcytic hypochromic anemia can be due to all the 5 options which has been given here. Beta thalassemia trait or anemia of chronic disease, sideroblastic and lead poisoning. All of them can cause microcytic anemia. So if they ask you what is the confirmatory test for iron deficiency, you will have to do a serum ferritin level. So it's important that we should read the question carefully, look at the smear and identify it. Sometimes if you have a filled with target cells, if you had it totally target cells which were filled and the MCV was a little more lower possibly, then it could be thalassemia as a diagnosis that you see. If you find basophilic stippling, then lead poisoning is a diagnosis there. So based on the smear finding, you can differentiate these anemia. So smears are a very important question. Again, they belong to pathology, but clinical scenario wise, they can be put in medicine or even pediatrics. You can get these questions. Again, one more image that's being kept here. You are seeing a peripheral smear. And this is a young male with recurrent episodes of jaundice, pallor, and splenomegaly since childhood. You find that the hemoglobin is 9.5. Reticulocyte count is 5.8%. That means it's elevated. MCHC is very high. MCHC normally is 29. MCHC is very high, 37. That's a gold standard. You know, MCHC is high in only one condition. That is hereditary spirocytosis. So here you can see what we call it as the football cells. You know, no central pallor at all. Spirocytes we call them as. And here already they have given it as osmotic fragility test positive. What is the most characteristic finding that you're seeing here? So you can see here, spirocytes, Howell-Jolly bodies, spirocytes, basophilic stippling, elliptocytes, fragmented RBCs, target cells, increased polychromasia, bite cells, and heme cell. So see the option here, very, very close, you know, spirocytes and Howell-Jolly bodies, spirocytes and basophilic stippling. Now here, the answer is spirocytes with Howell-Jolly bodies, not basophilic stippling, because basophilic stippling classically seen with lead poisoning that you see it here. So what pointed arrow is a Howell-Jolly body. That is. Again, here we have a malaria endemic area. Person is coming with fever. Person is coming with the fever there. The peripheral smear shows this. You can see this intra-erythrocytic parasite. You can see here. What is the most likely diagnosis? Again, remember, they have written very clearly malaria endemic area. So it's our, it's either Plasmodium falciparum or vivax. But here, very characteristically, you see this Maltese cross appearance. Very, very characteristic of babesiosis. Again, remember, babesia we don't see often in India. But this image you should always remember. Intra-erythrocytic parasite is vivax, falciparum, or your entire Plasmodium, and babesiosis that gets this Maltese. Whereas in the falciparum or vivax, you can get the Chigeons, you can get the form ecole, form applique, all those things, ring forms, etc. You do not get these Maltese appearance. This is very, very characteristic of babesiosis. So this is like they are giving a clue, but again, they have written malaria endemic area. That is misleading you. So it's very important for you to understand it, read it properly, and then write the answer. Again, very common in respiratory system, they can give you the flow volume loops. Okay, various flow volume loops are there. So here they have given you a 65-year-old male, chronic cough, progressive dyspnea, and the flow volume loop, you see the classically scooping of the expiratory curve. This is the normal, the dotted is the normal. So inspiration is fine, expiratory scooping, very, very characteristic of COPD. Please remember, please see these images. One of the flow volume loops will be asked for you as an image whether it is a COPD or is it fixed extrathoracic obstruction, fixed intrathoracic obstruction, is it a restrictive lung disease? Very important and very straightforward this is. So please see the loops correctly and then you will be able to identify the diagnosis there. Here we have a 60-year-old patient with scleroderma, comes with melena. HB is low and microcytic anemia. That means GI bleed is there. And this is the classical appearance. Okay, they have given a nice description here, but sometimes they may not give you a description. They just say UGI scopy finding is this. You can see this streaks like the watermelon skin. So this is what we call it as a watermelon stomach. Very classically seen in case of scleroderma. But here the question is, what is the diagnosis? Is it portal hypertensive gastropathy? Is it gastric antral vascular ectasia? Is it gastric carcinoma? Is it peptic ulcer disease? Please remember this watermelon stomach classically is GAVE. Okay, so GAVE, that is the gastric antral vascular ectasia. That is what it produces this image here. So that's the pattern that we are seeing here. I know many of you have joined. I think for the next question, you can put up the answers on the chat box. I'll go on to the question and then we'll discuss it. So here a 3-month-old child comes with recurrent cyanotic episodes during feeding and crying. On examination, you have central cyanosis, clubbing and a harsh systolic murmur in the left upper sternal border. The X-ray is showing this. What is the hemodynamic abnormality? I know the X-ray is very classical. All of you know the diagnosis here. It is TOF. But the question here asked is, what is the hemodynamic abnormality? Is it right to left shunting across the VSD? Is it left to right shunting? Is it pulmonary venous congestion? Is it obstruction to the systemic blood flow due to aortic stenosis? All of you know that it is tetralogy of Fallot. This is the boot-shaped heart which you're seeing, upturned boot shape. There is pulmonary stenosis, so aortic stenosis is wrong. Left heart failure is not there. The shunt is from right to left, right? That is why it is a cyanotic heart disease. So the answer for this is A. Answer for this is A. Okay, let's go on to the next question. You can answer it on the chat box. 25-year-old, 2 weeks history of widespread itchy rash on her trunk. Initially noticed the oval pink patch on the upper chest and later the skin lesion described symmetrically along the lines of the skin cleavage called as the Christmas tree pattern. What of the diseases? Pityriasis rosacea, it is psoriasis, tinea corporis, secondary syphilis. Again, please, here I have given you a very good explanation and description. Sometimes you may not get this description. They may just give you this image. All of you remember it. Answer is A, that is pityriasis rosacea. This Christmas tree pattern is very, very characteristic of pityriasis rosacea that is there. Again, here I have given you the description. Many times they may not give you the description. They may just say Christmas tree pattern of reddish macular lesions is described in which condition, or they may just give you this image and ask you to identify that is there. Very, very common questions are coming up in the ECG. So you would get at least 2 or 3 ECG questions. So here we have given a history here. Again, these sort of questions are coming more long stem questions. And they may have an image also, then you have to diagnose. 72-year-old, history of syncope there, fatigue, sickness, etc. And ECG shows a dissociation of P waves and QRS with regular atrial rate, ventricular rate of 40, atrial rate of 80. So you can see here the P waves are coming on their own and the QRS is coming on its own. The Q to Q is coming regularly. The P to P is also regular. So there is no evidence of ischemia on this ECG. What type of heart block is it? So it is a complete AV dissociation. P waves are coming on their own. QRS is coming on their own. Anybody? What is the answer for this? Is it A, complete heart block? B, idioventricular rhythm with junctional escape? Sinus node dysfunction with AV block? LBPP with complete heart block? Morbid's type 2? Yes, AV dissociation. It is complete heart block only. So severe bradycardia, atria is going on its own. A very, very common ECG that is kept. So please remember, you do get ECGs like this. You do get ECGs of arrhythmias. So make sure you see the ECGs of arrhythmias very clearly. Also, look at the ECGs of SVT, VT, bradycardias, heart blocks. These are the common ECGs which are kept for you in the exam. We'll go on to the next one. Okay, a 45-year-old treated with tuberculosis comes with hemoptysis and the X-ray is showing this finding. What is your diagnosis? So they have described the finding here. Sometimes they may not give the finding, they may just keep this X-ray. What is your diagnosis? Is it pulmonary tuberculosis reactivation? Is it lung abscess? Is it aspergilloma? Is it bronchogenic carcinoma? So I think the answer that you have written is pulmonary tubercular reactivation. That's wrong. What you're seeing here, you can see there, this is a cavity with a crescent here. That's written here. Air crescent sign is very, very characteristic of aspergilloma. Please remember, air crescent sign is classical of aspergilloma. It's called as the air crescent sign of monad. Monad's air crescent sign. Lung abscess, you will find an air fluid level. And pulmonary tuberculosis reactivation will not be able to, the X-ray might look similar, but that air crescent sign is very characteristic of aspergilloma or a clot in the cavity there. So a cavity which is filled with clot. Okay, we'll go to the next question here. A 30-year-old, recurrent episodes of upper abdominal pain, fever and jaundice. Recurrent cholangitis is there, and this is a CT scan shown. You can see the biliary radicals are dilated, and there is a very characteristic finding that has been described here. So what is your diagnosis? So remember, this is a young patient who has come with recurrent cholangitis. So it's possibly a disease which has been there for long. So is it primary biliary cirrhosis? Is it Caroli's disease? Is it hepatocellular carcinoma? Is it a choledochosis? So what you're seeing is a central dot sign. You can see that very classically in the dilated biliary radicals, whatever is seen, a central dot is seen, which is a hypointense lesion that's seen. Very, very characteristic of Caroli's disease. There is an ectasia that you see that. You don't find it in HCC, neither in choledochosis. Choledochosis will have cystic shadows, and primary biliary cholangitis will have intrahepatic or extrahepatic cholestatic picture. So dilation only will be there. The central dot sign is not seen. A 40-year-old presents with hyperpigmented thickening velvety in the axillae groin. She reports history of obesity, family history of diabetes. Her fasting glucose is 145, HbA1c is 7.5. She does not have any other symptom. What is the pathophysiology of this skin lesion? So all of you know what is the skin lesion? Very, very characteristic. Anybody, what is the name of this disease? This is acanthosis nigricans, right? All of you know it is acanthosis nigricans. Classical hyperkeratotic lesion, and you can see the skin tags also. These are markers of insulin resistance. So the answer here is insulin resistance and the activation of the IGF. So the answer is A here. The other mechanisms, I'm not going through that. A 35-year-old, 7-day history of fever, headache, myalgia, non-productive cough. Also has recent history of travel to northern India where exposure to rodent habitat. So he has a maculopapular rash in the lower abdomen with the SCHAR, and you find that the liver enzymes are elevated, WBCs are increased. What is your diagnosis? So this is the classical SCHAR. This sign is called as the cigarette burn sign, burn cigarette sign. So you know the diagnosis is scrub typhus. So scrub typhus produces this SCHAR. Again, these descriptions may not, they just give this image, scrub typhus. They can ask you treatment. So please remember the treatment of scrub typhus is doxycycline. Doxycycline is the main drug that is used, and in severe forms you can use azithromycin with meropenem. A 42-year-old, dry cough, fatigue and occasional chest pain. She had some blurred vision. Chest X-ray shows this finding. You can see that bilateral hilar lymphadenopathy, what we call it as a Garland sign or the 1, 2, 3 sign. Hilar and the paratracheal pretracheal lymph node. And FDG PET shows the panda. This is the uptake in the lacrimal gland and the parotid gland. You can see the parotid gland uptake. Which of the most possible diagnosis? So remember, this is a very, very characteristic finding that you get in case of sarcoidosis. Again, remember, if it is a unilateral hilar lymphadenopathy, the diagnosis becomes tuberculosis or malignancy. Bilateral hilar lymphadenopathy, it is sarcoid, sarcoid and sarcoid only that you see there. Very rarely you can get it in lymphoma, but this sort of pattern most often is due to sarcoidosis. Again, remember, please remember that image-based questions Classical CT, MRI, X-ray findings you have to know, like the ECG findings and the peripheral smear findings. Also, you do have some mnemonics. Make sure you revise the mnemonics on a regular basis as the exams close by. You have now. So you do have one line type of questions, as I said, drug of choice for particular things, image based, which I've already said. Clinical scenario questions, that is something which is increasing. And what is also increasing is the integrated questions, like clinical scenario, pharmacology with medicine, pathology with medicine. And one more thing that is happening is you match the following. That is, they give 3 statements and then they give 3 more statements, or 4 statements and 4 statements. You have to match it, which is for what? 1A, 2B, 3C, like that. It takes a little more time. So such questions are also increasing 10. And assertion reasoning questions, that is also increasing. Why is it happening? All are because of this reason, except, or all are because of these pathophysiological mechanism. This one sentence is not due to that. That is also on an increasing trend. That is what is happening. What is of noted in the last few years is certain pattern recognition is there. NB often repeats concepts. I'm not repeating questions. It repeats the concepts. That's how you know that infectious disease or your HIV, tuberculosis, ECG, MI, atrial fibrillation, or your surgical acute abdomen, certain toxicology. Those are high yield questions are there. The slight wording changes are there in this one. Newer guideline, if anything, has come. Like as I told you, the new tuberculosis guideline has come, but it has not been implemented in India, so unlikely to change here. But you know, the TB guideline changed last 1.5 years back, where you had the HRE going for the continuation phase. So that's going to come here. Sometimes the old question only opposite framing will be there. Like if they would have asked the treatment, now they will ask the diagnosis. If they've asked the diagnosis, now they'll ask the treatment. Also, there is, the most debated question option is often correct. Extreme obsolete, no, always or never are usually wrong. And sometimes this trend has come down a lot. All the above, if it is kept, it is most often right as an answer. But again, please remember that trend has come very, very less now. So don't choose all the above for everything, but generally that's the answer. For completely unknown questions, statistically C option is the highest. That is some questions which you completely have no idea and you want to mark. I don't suggest that because you have a negative that is going to come with it. They say that of the A, B, C, D, C has 27%, 25% is equal to all. So 27% chances are C is the option. But again, remember the options also can be shuffled. The questions also can be shuffled. So this doesn't hold good all the time. With just around 1.5 months remaining, a few pointers towards what you can do in this final sprint. Do attempt mock test because that is giving you exam like conditions because it is timed. You will be in that exam like mode. That is what's very helpful. Revise the notes. Please solve the PYQs for the last 5-6 years. Look through the PYQs. Quite a lot of repeat is there. However, what we saw in the SS yesterday, there was hardly 10% repeat, but then questions of the similar systems were asked. Revise the high yield facts. As we said, the antibiotics, vaccines, newer guidelines. Analyze the mistakes after your mock test. Weak areas, make sure you identify where is wrong and focus on improving that. Give more time for that. That's what you can do now. Avoid new topics. That's something you would have kept off for something. Unless they are a high yield topic, please do not start it now. Stick to the revision of the already known topics. That's what I suggest. Don't over attempt. Don't over attempt to get 200 on 200. 160 or 170 is a very good attempt, confident attempt. If you are getting that consistently, that is a good one. You don't have to worry. Very, very important. Take care of your health. Have food at proper time. Stay hydrated. Sleep for at least 6 hours. That's mandatory because otherwise your performance will eventually go down as the exam gets closes. Eat light meals. Stay hydrated. A lot of places in India now you have a lot of heat that's going on. So make sure you take care of your health more importantly. Common mistakes to avoid, what is noted, ignoring the PYQs and not doing mock tests. This is something which you should not do it. Make sure you see it. It will repeat. Overloading with too many books and maybe too many platforms. Various platforms are there. various mock tests from various platforms are there. Stick on to one, whichever you have started. The books also stick on to one. Do not simply change the books. If you're doing it, you have to do it well in advance, not at the last moment. Neglecting community medicine and pharmacology. These are high scoring. They have a straight questions coming. So please don't neglect these two topics. Read it. Poor time management in exam. As I said, 40 questions, 42 minutes. You have less than a minute per question. Do not waste time. Because there may be questions which you actually know. If you waste 1 minute or more on one question, then the question which appears later might be a very easy question you might miss. So if you feel that the question is becoming a little long and it is taking more than 1 minute, skip it and go to the next. Do not waste time. Avoid guesswork. As I told you, the percentage of C being right, negative marking is there. Avoid the guesswork. That is very, very important. Consistency is a key. That is very, very important. In the last 2 months, you have to be consistent. Read every day, the few hours or whatever hours you're taking. Do the mock test. Analyze the results. Stick to a routine. Do not change the routine. Discuss. It's very important. Quality is more important than quantity. Solving 1,000 questions, 1,500 questions a day, it is no use unless you know what is the gist of these questions, what is the understanding you get from the question. Quality is always important. Even if you do 200 questions with good quality preparation, that is very, very successful rather than doing 1,000 or 1,500 questions per day. And as a rule, I say revise, test, sleep, and repeat. So this is the keywords that I would want you to remember in the last 2 months. Keep revising, appearing for the test, sleep, eat obviously, take care of your health, and then repeat it every day. This is the mantra that I would want you to go on with. You got this. I know your preparation has been good. All of you have been preparing well for all this time. You have been appearing to your exams. You have been preparing for the mock tests and all those things. I'm very sure all of you will do really well in your exams, and all the best for NEET PG 2025. Thank you for the hearing. We will be taking up the questions. Any one of the students have any clarifications? I am ready to take it up now. You can put it in the chat box. I think there are some questions which have come. Okay. If you are still in the third year and preparing, yes, you do have time now. So concentrate on your passing your MBBS. That is very, very important because that's a totally different sort of game that you have here. Parallelly, do concentrate on individual subjects. Remember, if you read it well once, you don't have to read it again and again. So whatever subjects you're reading now in third year or the final year, read it well in a way so that you can remember it for a longer time. That would be the go for somebody who is starting from the third year. For 2026 guide, a lot of things are going to change. Patterns might change, but a lot of guidelines are changing. In the later half of this year, we are expecting a lot of the Indian guidelines to change. So you require to be updated with the guidelines. Most of the books would get the guidelines with that. For 2026, you have more than a year now. So what I would advise you is to start, identifying which books you're going to read or which material you're going to follow and stick to that. And the time and what are you going to do? Are you just going to sit and study, or you're going to work or something and then study parallelly? So how much of time of the day are you ready to give for the subject? That is very important. So you have a long process there, but make sure you start it now itself. Identify the material, identify your times that you have, how much of time you're ready to give for it, and then start the process in the same way. The next, the same thing. Internship is the same thing which I told for third year. You have quite a good time. Is it good for giving INICET? Remember, INICET, the format is different from what is in NEET PG. You can give both, but yes, INICET has a different format. The number of questions, the patterns or the importance given to subjects are a little different. They are more of assertion question, more of match the following type of questions. Recall questions are less. You can definitely try INICET because you're preparing for that. But the patterns are a little different. Otherwise, the preparation is the same for it. Important topics in pharmacology. Remember, pharmacology is directly related to medicine. So all the drugs which I've told you, or diseases that are there in medicine, which I've told you importance, all the pharmacology of that is absolutely important. Newer drugs for each systems are important in pharmacology. Again, of late, they have asked you drug dosing, has also asked like the drug dosing of malaria, drug dosing of tuberculosis. All those things are also going to be asked. And luckily, COVID is no longer there, so COVID related questions might be less. Questions for PYQ. There are a few books which are available, including the book which I have put, my book, which is getting launched this week. We have covered more than 10,000 questions, Harrison based only, which has almost all the PYQs for the last few years. There are books available for that, including the book which I have shown. Okay, first reading not completed. I know it's a very common thing that can happen, that you wouldn't have finished everything, but I hope that you have finished at least the high yield parts, especially of medicine, surgery, community medicine, as well as your pharmacology. Those are the important portions that you should not miss. So you should start revising them. And if you have some time permits, then you can read the other subjects also. So that's the big point. You have finished the number of subjects, 9 out of 18 only finished. That's what, when you start, you should not start subject wise, you start together. Do not leave anything for the end. I do agree, finally it happens the crunch, you give importance to all the main subjects, and finally you do not have time for the, almost 4 or 5 subjects are pending. So it is a problem if you start in that way. You should always start it together. And since most of the subjects questions, like if I say pharmac, micro, patho, are related to medicine, surgery, so it has to be done parallelly together. That is the best way to read for each subject. Most important subjects, as I told you, is the medicine, surgery, which has the almost 80 to 90% of the questions, and then pharmacology and community medicine. Being an intern, that's what you have to make sure how much of free time you have per day. And then based on that, you will have to get a schedule done based on what you can read. Which lead to see on the ECGs? Normally, ECG has a 12 leads only. So normally when they give you the 12 lead ECG with the history. So you will have to see all the leads of the ECG to make a diagnosis. But if they're giving a rhythm, rhythm abnormality, that is an arrhythmia, either a ventricular tachycardia or atrial fibrillation, you're going to look at lead 2. Lead 2 is the rhythm strip. That is where you can make out the rhythm abnormal. Nobody finishes 2 or 3 revisions. Anybody who is told is 2 or 3 revisions, it takes that much more time. So whatever you have finished is good enough. The shifts of exam, I remember very well, maybe some 6 or 7 years back, we had exams conducted for 7 days. So 7 different set of exams came, and there was a equalization of the exam. The marks were equalized. So 2 shifts is nothing compared to what had happened that time. 7 or 8 exams were there on 7 different days, and the exam. So the difficulty level, yes, there might be some change between the shifts, but then there is a normalization done. The normalization is very, very reasonably done. So you should not be worried about which shift you get it. First and second year subjects have to be covered in relation to the clinical subjects. There is no use of reading the first and second year subjects alone. Do it in correlation with the clinical subjects only. I know internship just finished, 2 months remaining. It is too short a time to actually, go through everything unless you have been preparing for it. So read the PYQs. That's what I can say. 2 months you can read the PYQs. Look for the images, image-based questions that you can do well. How many PYQs? It depends upon. Remember, the last 5 years ka questions means anything around 2,000 to 3,000 will be there. So you have to go through that. Yes, high yield topics are an important thing, but they are not the only thing. So you should not start a new topic, but other topics have to be revised in the last 2 months. High yield topics, I just made a list of it. Not necessarily those are the only ones which are important. I think who could not log in on time, the entire session is available. I think social media, I think on YouTube or this one, it will be available. They will put you the link so you can go through the full session again. Which platform or what? There are very good platforms. There are very good books. Most of your questions are based on the standard books that is there. Indian books will have the Indian questions. If I would say my book in the last 3 NEET PGI, if you put all subjects together, almost 70 questions every year have been there in my book. Similar would be the state from Harrison also. It is important not to read one subject. You have to read 2 or 3 subjects simultaneously. Don't do the mistake of just reading one subject. give gaps and read simultaneously other topics also. It's about reading. It's not about the amount of revisions. If you have done a very good reading well and you can recollect it well, even one revision is sufficient. It's a very difficult thing to avoid FOMO at this time. This is a very natural process. All of us have been through it. Maybe at our times, we had physical exams, physical papers and exams were there. Now you have the computerized exams and it's a little more, tech things there are there. But that's a very natural thing. Everybody has to fear it. Just keep yourself positive, trust your preparation, you will do fine. So the earlier, if you're preparing, you have more time, but along with that, you have your regular subjects also. So you have to finish them parallelly. But that's what, when you're reading a subject, make sure you read it well so that it will be helpful for you. You don't require to read it all over again. Once you do your preparation, it will be easier to do that. So when you read it first or read it for the first time, read it that well that it remembers or it remains with you in a better way. That's how you can prepare better. Again, please remember, read the questions very carefully. Many times it is double negative that is written there in the question. Off late, the negative questions are gone off. The double negative, that is no longer given. But sometimes there might be just a little catch. It might look like iron deficiency, but actually it would be thalassemia, right? Ferritin might be normal or high. That's very important. So read the question completely and then answer it. So that's very important that you have to read it. Again, remember, all systems are important. Just because I told you the high yield topics are coming from 4 or 5 systems does not mean that you will not get questions from immunology or you will not get questions on renal. You would get questions there, but maybe the number is less. As of now, whatever I've told you is based on the patterns that have been there in the last 5 to 6 years. Next year, when I present the same topic, maybe if we analyze the questions that are coming, the high yield questions might be a little different. But you have to read all the topics. But these are the high yield concepts are from the questions which are most frequently asked. To integrate, very important, all the drugs which we study in pharmacology are going to be used in your diseases and medicine. All the microbiology and pathology that you learn in second year will be a part of medicine and surgery. So you will have to read it in that form. Tip to avoid negative mark, do not mark it. That's all. You will not get negative mark. If you don't mark something which you're not sure, that's the only way you can avoid the negative mark. Read the question when you mark. I know it's a little difficult now because in that 40 questions in 42 marks and that questions you won't get it again. So, but I would still suggest if you're very, very unclear, do not mark it. Do not mark it. If you feel it is very, very not clear to you, do not mark it. Avoid the negative. Reading the question clearly and reading it again, reading the options, again, reading the options and the questions clearly will help you to choose the right answer. And if you're still not able to make out the answer, leave the question.